Good evening, everyone. Thank you for taking your time and joining this clinical indicator program. The last week, we completed 9 clinical indicators and the program was well received. We had over 1,000 participants who joined us through Zoom and also through our live Facebook and YouTube updates. So today we are going to be having another set of 9 indicators, and we have with us none other than Dr. Sanjeev Singh, who will be handling the first 5 indicators. Dr. Sanjeev Singh is the Medical Director, AIIMS Faridabad, Chief Medical Superintendent of AIIMS Kochi. He's a well-known name in quality management principles. He's implemented a lot of programs and projects, an excellent faculty, and today, sir, brings to us the 5 important indicators, and I'm sure it's going to be a great experience learning from Dr. Sanjeev Singh. Over to you, Sanjeev, sir, and thank you very much for accepting our invitation.
Thank you so much, Lallu, and congratulations for again bringing up all fantastic programs under Kaho. So great work, and I think what you do on weekly basis is a magic. But it's a great service to quality and healthcare. So thank you for doing all the hard work. And I'd also like to thank your staff for coordinating, because I think on the background, there's a lot of coordination which is required, which they do wonderfully well. So thank you so much, and we'll get started. I will share the presentation. As Lallu said, basically in the 6th edition, there was a slight change in the indicators, and it was felt that the clinical presentation has to be appropriate and the clinical indicators have to be brought in. And that is how there are these 18 indicators which are present. I'll quickly start without further ado. There is an indicator which is required, which is mandatory, which is sepsis. Now, we have done quite a good work in all the hospitals with infection prevention. We are doing decently well in all the accredited hospitals with respect to antibiotic stewardship practices, which is getting better and better each day. And thank you so much, all the hospitals and the healthcare professionals, for doing fantastic work. Sepsis, again, is a very important indicator. In a very simple language, sepsis would be if there is an infection. It could be device related or otherwise, which could be bloodstream, urinary tract, surgical site, pneumonias, plus if there is an organ damage. So in a very, very simple language, if there is an infection followed by an organ damage, that is called as sepsis. And this is very important to understand, to be able to capture, because this is all done at ER, where it is very chaotic. Patients have just come in. You have to take the briefing, your history of present illness and things like that, and presentation and act. So that is where it is extremely important. Now, as per the surviving sepsis guideline, which is the main body which basically guides what needs to be done, there are 5 salient features, and that is in 2002, basically this was all brought in. So one important marker is in lactates, and lactate more than 2 millimoles per liter is a good indicator of sepsis. So one salient feature for sepsis, which is basically life-threatening organ dysfunction, which has been caused because of this infection. One important aspect to prove sepsis and calculate this or start tracking is lactates. Second is that before giving an antibiotic, any broad spectrum at ER or at any place, either in outpatient setting, daycare setting, or in inpatient setting, it would be also important to obtain blood culture. We generally give antibiotic and then the blood cultures may present as no growth, and it may not be very substantial. So it is important. That's the second important thing. Third is a broad spectrum antibiotic according to your institutional antibiogram should be immediately given. So that is important to have your own antibiogram that should be known, and that should be given. Fourth important thing is to replace fluids, because there is infection and then there is an organ damage, and that is where the fluid replacements are extremely important. So that is close to 30 ml per kg of crystalloids, which needs to be given at any given point of time, which could be basically either a normal saline or a ringer lactate or 5% dextrose. Accordingly, you can possibly take a decision. So what needs to be tracked is that the percentage of sepsis patients at ER and ICU who receive this care within 1 hour. Earlier, when it got started by Surviving Sepsis campaign, it was 6 hours. And then it got reduced to 3 hours. And then they realized that the outcome has to improve better. And that now it has been reduced to 1 hour. And 1 hour bundle needs to be captured with all the 5 points which we mentioned. So the start time would be when the patient comes at the ER, or if they come directly, if they have been very critical, if they come directly into the ICU. So clinically, it is extremely important only because they are in a shock-like state, or it is a life-threatening, and organ damage is already there. So we need to act fast, and acting fast basically would happen because act fast is a good mnemonic for treating sepsis or at 1 hour bundle. A stands for antibiotic, C stands for culture, T stands for treating with IV fluids. F is a finding source. So source control in infection, as you would know, is an important indicator. And A stands for access vitals. According to the vital parameters, again, you would act on it. And then there is a support, which is given by crystalloids or vasopressors, and then transfer to appropriate setting. Now, how do you calculate it? The numerator would be all those patients where you have done 1 hour bundle capturing with those 5 salient features, and divided by those who are septic, those patients at ER or ICU, those who are septic. So again, I will like to say, because many of the patients may present at septic, many of the patients may present at acute kidney injuries, acute liver failures, looking like sepsis. So infection with an organ damage is a very simple example, and that should be tracked, and whenever there is life threatening. So, and that is how the example would look at if you have, and you could sort of benchmark it within your institutions because you have your own data. And if some patients are at 10 patients are sepsis, 9 you did, so that's 70%. How do you capture this information? It is through the lab reports, because you have to send some of these biomarkers, so you would know what exactly needs to be done. The ER medical record, because if the history would also say, and possibly you have done the SOFA score, and whenever you did a SOFA score, and if it is greater than 2 points, there is an indication of a life-threatening or a dysregulated host response, and that should be a good indicator. It should be done monthly. Responsibility is with any physicians who's the first point of contact, or at ER. ER should basically handle it. Uh, a higher percentage shows a good trend, because this 6 hours, 3 hours reduction to 1 hour, 1 hour is definitely challenging. But then if it is done well, and if you are more than 70%, that is a good sign. The outcomes definitely would be better. Lower percentage would be a bad sign. There are no benchmark figures up till now, but then it is important that we react to it. So managing with those vital parameters would be critical. Generally, like a SOFA or Q-SOFA could also be done with a respiratory rate of more than 22, mental health status and BP of less than 100. So if 2 or more signs are available, that should basically be a good trigger to be able to understand that it is sepsis. We need to capture it and do all these 5 salient features. And it could be presented like this: a good, average, and a bad indicator, and that could be a representation. So there are challenges with respect to this. Lactates are missing, incorrect documentation is there, and we don't know whose responsibility is to capture. So what defines 1 hour sepsis bundle? Basically all the above, because lactates have to be there, the antibiotic has to be there, fluids and vasopressor has to be there. Now, the next indicator, which is bile duct injury, and for all lap chole patients, and this is optional indicator. Basically, lap chole is one of the most common surgical procedures, so much so that now within the Ayushman also this has been taken out, because it has to be done at the public level hospitals. And there is a hepatic duct, there is a bile duct, and leading all to common bile duct. And during some of these surgeries, which is minimal invasive, there is a possibility of injuring the bile duct or completely injuring it, which should be sort of avoided. And that's why one of the surgical indicators has been also brought in. So bile duct injury with lap chole is an important indicator to understand the good outcomes or a good surgical skill. The KPI is basically looking at the injury, which would be either intraoperative or post-operative. Intraoperative also, it could be identified, or otherwise the post-operative things could also be sort of looked at. The intent here is we are looking at basically critical view of safety. And there could be either intraoperatively, there could be a cholangiography which could be done to be able to sort of give an information that the bile duct injury has happened. Otherwise, post-operatively, there will be signs of peritonitis, there will be signs of sepsis, there will be signs of leakage, and there will be signs of bile collection. And that would be so this surgical decision making is extremely critical. And all these injuries is to be sort of reported. It has a lot of clinical relevance because this is other than hernias, lap chole is again and cesarean section. These are very, very common surgical procedures within the healthcare institutions. Numerators are the bile duct injuries, and the denominator is all the lap choles which has been done, and it is into 100. And you could basically, it's very easy to sort of calculate. How do you capture it? It comes from OT log. It is going to be very difficult to capture unless there is a humility or an ethics uh, in announcing that there is a complication, or there could have been a complication by the surgical team, or there could be a very vigilant nursing or attending surgeon team. So if there is a non-blame free culture, and if that is good, then the collection of this data would be very important. It would be very difficult to get it from OT logs and OT notes, but an announcing a self auto-correcting and from the surgical team would be the best. So how do you interpret? So high percentage would be a poor trend, and low percentage a good trend. There is within there is a group which is called as SAGE, where they calculate this data, they pull in this information from all the institutes. So Society for American Gastroenterology and Endoscopic Surgery. Within them, they have said 1.5% is something which is an international benchmark, and you could possibly start from zero or look at that benchmark, and that would be easy start for capturing this surgical indicator. Now, there is definitely a problem because the surgeons don't report it, and they never claim that there is any complications from this the surgical procedure which they have done, and it is something else which could be responsible. So those are a cultural issue which needs to be set in, and definitely within the theater and OT notes, this would be somewhere missing. So a case of bile duct injury reported in post-operative period, will it be a case of bile duct injury? A question to all of you. Reported in post-operative period, will it be added as a numerator? Answer is yes, because even intraoperatively, post-operatively, we need to sort of capture this information, because this is part of the numerator and part of the bile duct injury collection of information. Now, we also looked at another obs and gynae surgical procedure, perineal tear, which is also extremely common. Within the National Patient Safety Framework of our country of 2020-2025, a 5-year plan, perineal tear was one of the common indicator which was supposed to be captured by all the public hospitals, and that is why it has been sort of made it mandatory. So the Royal College of Obs and Gynae and American College of Obs and Gynae basically have defined this very clearly. So these perineal tears are 1 to 4 degrees. So if it is a very small tear, which is just affecting the skin, that's the first degree. If the muscle gets involved along with the skin, that's the second degree. If it is deeper than the muscle, that's the third degree. And fourth degree is if it is also involving anal sphincter. Third and fourth degree is going to be very, very risky. And that is where I think the multidisciplinary team also needs to get involved, and that requires, because it is going to be extremely effective, and it requires a lot of attention. So as an indicator, it will be percentage of vaginal delivery where the perineal tears have been divided by uh, the number of surgeries which has been performed. It is extremely relevant because even uh, our own data, published data in an Indian setting shows a very high percentage, and there are perineal tears happening, and this could be definitely preventable, and that is where it could be just the first degree, which is also okay, which could be avoided by the episiotomy, but definitely it is important to be sort of looking at. So numerator is number of vaginal births with spontaneous tear. Denominator is total vaginal deliveries into 100, and that's the very easy way to calculate the percentage. Now, where do you capture it? Now, because this tear is happening at the labor and delivery suite or labor and delivery rooms. So at their register, or if there is an obs and gynae records, delivery records, notes, and the team, which also can announce. So responsibility lands up with those team, the faculty and the staff at the labor and delivery. It has to be done monthly. So higher percentage it shows a poor trend, and lower percentage it's okay. The published literature, that is in a practice bulletin, it has been reported as 53 to 79%, which is extremely high. And that is something which needs to be prevented and should be sort of taken care of. So we need to look at first degree tears, definitely could be a possibility because of tier 3 PHC, CSC delivery, but beyond that should be all preventable. And that is how it should be sort of presented, and good, bad, fair indicator. So common problems in the data capturing process is underreporting and missing of the delivery notes. So a very quick question to you, and you can respond on the chat. What is the worldwide incidence of the perineal tear reported in the vaginal delivery cases? And I just mentioned there's a practice bulletin which reported this particular number. And that is why it is important in an Indian setting to capture perineal tear as one of the indicators. So, right. So very good. It is basically 53 to 79%. And that is where it is extremely important to capture this information. Now, fourth, the indicator is looking at percentage of POCT, point of care testing, for any clinical intervention. So it's optional because it is just coming in our country. There are lots of point of care tests which got introduced during COVID. It could be PCR based, non-PCR based. It could be for just for good biochemistry. It could be a decent hemat. So it all exists within the hospitals. A glucometer is a good point of care test, which is very, very common. A urine dipstick tests for protein ketones is again a very, very common test. So it exists in the hospital setting, and that is where it was important to bring it into one of those indicator and practice, because it helps in the good clinical decision. So point of care testing is a laboratory test which gets gets conducted at the bedside, and it could be electrolytes, it could be troponin, it could be blood glucose, blood gases. So all of it is not sent to the central laboratory system, and it is all done at the bedside for faster, rapid decision making. So one of the group which basically defines what consists of POCT is CLSI guidelines internationally. Nationally, they have still yet to adopt. ICMR has released the guidelines on POCT, which has been sort of also debated, but they have released these guidelines more so for areas in PSC, CSCs where the lab is not there, so point of care test can be introduced and the immediate clinical decision can be taken. WHO has offered a decent framework or POCT. Because it needs to be sort of sensitive, specific, and making it more affordable and rapid. So there is definite clinical indication of introducing point of care testing at bedside, whether it is critical care, emergency, or any of the procedural areas. Now, the numerator is number of POCT tests that resulted in treatment and intervention divided by number of POCT where the clinical intervention was deemed necessary. So deemed necessary is mostly in an emergent setting. It could be a patient coming in with STEMI, non-STEMI, and then you get an ECG done, and the other marker would be troponin. Or you don't realize whether it is alkalosis or acidosis, and you want to get an ABG done for clinical decision or an intervention. So that's how it would go, and it would basically gets captured from the POCT logbook, which is very difficult because it is there everywhere within the hospital, and non-calibrated equipment would be extremely difficult. It could lead to bad decision making. But then if there is an activity sheet, or if there is a result which has been sort of captured in the vital parameters or in the lab test record, you could sort of uh, retrieve it from there. Responsibility would depend from the nursing rather than lab managers, because point of care test mostly is done in critical care setting and in emergency room setting. So it will be responsibility of the nursing to capture this information. Higher percentage shows a good trend. I don't know. I'd leave it to you for judging, but an immediate clinical decision is going to be very critical. And if it is done for something where the outcomes improve, it is a good sign. And lower percentage shows a low trend. Unfortunately, it is still coming in a decent way in our country. So there are no national and an international benchmark. So that is how it could be represented. That could be 100% is a benchmark, and then there is a good indication. Common problems for capturing is because it's non-calibrated, you don't know, it is not recorded, and it goes unnoticed, and intervention it gets done, but it is not documentation. Documentation, as you know, is a decent problem within our healthcare organization. So a very quick question, and you could respond is in a chat box. Which of the following will be captured in the KPI, which is POCT? So blood glucose check using glucometers, trop I showing higher values, or lab test done to check creatinine. So which of the above would basically fall into point of care testing? So trop I is one of those most favored point of care testing, because as a American Heart Association has also said acute coronary syndrome, a very relevant test is ECG and TROPI, and that is where the decision making, and it needs to be immediate because you need to sort of move the patient to the cath lab and get a CAG followed by PTC if it is required, or primaries to be done. So finally, another last indicator from my side, it would be percutaneous intravenous contrast extravasation. It is mandatory because it's extremely risky. And there needs to be contrast is happening left, right, and center at nuclear medicine, at radiology, and there needs to be a decent precautions which needs to be taken. Now, who gives this particular guidelines? It basically comes from American College of Radiology or Royal College of Radiologists. And fortunately, in India also, the Society of Radiology has included this as one of the indicators to measure their work. So contrast extravasation is a problem. As a KPI, what we need to measure is the percentage of IV contrast administration, which leads to extravasation. It is a common indicator, and that is why it got included within this 18. And that was one of those indicators which was available for radiology, which we were not doing it earlier. Redos were done. The clinical correlation was done. External, internal peer reviews were already done. Radiation safety was already done. Clinical indicator which was left with is extravasation. That is preventable, and that is why it is of relevance that you need to improve the outcomes. What it could lead to is a higher degree of pain, maybe an increased stay, increased cost of the patient, and some treatment would also be required other than disturbing the quality of life of the patient within the hospital. So numerator is number of extravasation events. Denominator is total number of IV contrast which got administered, and That is how the formula is. So if there is one case divided by 100 CTs and MRI where the contrast has been given, it would be it could be 1%. Now, again, it is very difficult to capture the source of this information. It would be basically coming from the medical records whenever the patient is either shifted from nuclear medicine or radiology, or it would come from from the nursing notes. So adverse event, if there is a very vigilant radiology group where they capture all the adverse event, so it may also come from the incident report. So there needs to be a continuous flow. A higher percentage shows a poor trend. The National Radiology Society, basically IRIA, also says that there is a national benchmark of less than 0.11%. And almost similar reporting comes from American College of Radiology, which is 0.7%. So it definitely exists. If the organization doesn't have any data, they can start with 0, and it could be represented in various graphical form to understand whether it is good or bad indicator. The problems for data capturing would be underreporting, if there is an untrained staff, and if they rush through the presentation or administration, and if the cannula was not in place and it wasn't patent. So a last question to all of you would be, and you could respond in the chat box. Right. Sorry about that. That is our founder, Amma, who prays for everybody's health and happiness. So extravasation happening in chemotherapy patients while administering chemo drug is included in the numerator. Is it true or false? And so basically, we are looking at contrast. So it would be just limited to contrast. So anything else other than this would not be included in capturing this particular information. So thank you so much. I'll pass this baton to Dr. Suneel Mundkur, who is basically a very dear friend, a fantastic human being, a great clinician, and a professor of pediatrics at one of the finest medical colleges in the country. And he would be covering the rest of the indicators, and post that will be available for question and answer. So over to you, Dr. Suneel.
Thank you, Dr. Sanjeev Singh, for making my job so difficult.
Suneel sir, just 1 minute. Sorry. Thank you so much, Sanjeev sir. Would like to take this moment to introduce our next program. My team will be putting up the program. Dear friends, as you're aware, we will be starting the masterclass on department-specific indicators. So this is the masterclass series 14 of CAHO, Empowering Clinical Excellence, Clinical Indicators. We are planning to start on the 8th of August, every Friday between 4 p.m. and 5:30 p.m. We have one departmental indicators. The clinical indicators of one department will be discussed. And we have experts from these institutes, Aster DM from Dubai, Fortis Healthcare, Sri Ranga Hospital, Chengalpet, Dr. Mehta's Hospital, Chittaranjan National Cancer Institute, Ganga Medical Center, HCG Enterprise, Opolo, Sundaram, Nirmal Sai, Zamindar Eye Hospital, Institute of Neurosciences, Calcutta, Aster DM, Baby Memorial, Diagnostic Division of CAHO, Sakra World, Clinical Dietetics Forum of CAHO, Narayana Health Dental Forum of CAHO. So the 18 broad areas will be discussed for 18 weeks. That's the idea. So we will go in depth into discussing clinical indicators, let's say from cardiology and cardiothoracic surgery by the Fortis Healthcare Limited. So requesting all the participants to use this opportunity and register for this program. Registration links are open. There'll be a lot of learning, I'm sure, and there can be good discussions. All your questions can be answered. We are also going to be issuing a certification by end of the 18 programs. If you have any group booking, and kindly contact Anita or Meenakshi or any of the CAHO members. Thank you so much. I would now hand over to Dr. Suneel. Suneel sir, sorry for the interruption. You can continue.
Dr. Lallu, and thank you, Kaho, for making my job difficult because it's challenging to talk after Dr. Sanjeev Singh's deliberations. Let me try to do justice to the topic and the hype and settings created by Dr. Sanjeev. So I'll be dealing with the remaining last 4 indicators which are left with. So the first one is on nuclear medicine. The indicator is percentage of adverse reaction to radiopharmaceuticals. Adverse drug reactions are unintended response to doses prescribed for humans. An adverse reaction may predict risk for future administration or warrant prevention or targeted treatment or changes in the dosage or withdrawal of the drug. The good news is that most of the radiopharmaceuticals are administered only once, and the reactions are extremely rare. So there is no question of changing the dosage or withdrawal of the drug or prevention of this drug administration in such scenarios. Any product that, when prepared for use for therapeutic or diagnostic purposes, contains one or more radionuclides or radioactive isotopes is called radiopharmaceutical. And radiopharmaceutical can be used for 2 purposes, that is diagnostic and therapeutic. Diagnostic agents are containing an isotope that emits photons or gamma radiation, which can be captured with the SPECT, or therapeutic agents whose isotope emits beta or alpha particles to ablate the tissues in the body. Unlike conventional drugs, radiopharmaceuticals rarely cause adverse reactions. However, when they do occur, they often cause alarm both to the patient and healthcare staff. And if you see the common adverse reactions to adverse radiopharmaceuticals as given in the Navy Standard Book, include nausea, decrease in blood pressure, hives, bradycardia, dyspnea, itching, chills, muscle cramps, bronchospasm, flushing, cough, and dizziness, for which you need not worry. I'll tell you the dangerous part of it subsequently. This is a mandatory indicator if it is in the scope, if the nuclear medicine in the scope, otherwise there's no need to capture this data. Frequency is monthly and it includes outpatient, inpatient as well as daycare patients. The numerator for this indicator is the total number of patients who developed adverse reaction to radiopharmaceuticals into 100 divided by the total number of patients receiving radiopharmaceuticals. So it's a percentage calculation, not a ratio. And the data shows you can retrieve it from EMR, HIS after entering the appropriate data. If you have totally electronic medical record, you can have a area or option to capture this data. There should be provision for entering the manual or electronically collected data, and you can have apps or online forms to capture this data. Nuclear medicine register can have this data, or who can collect this data? Either nuclear medicine nurse or technician in the nuclear medicine department, patient care coordinator or doctor. You can assign this job to any one of these to identify, to capture this data. What trends indicate improvement of concern? As I've told you, it's very, very rare incident that happens for adverse reaction to radiopharmaceuticals. Hospital has to develop its own benchmarks. The incidence of such adverse reactions are, internationally it is accepted that's around 0.01 to 0.1%. That in 1 in 1,000 patients may develop this kind of reactions, and majority of them are allergic reactions. So common challenges, as we have already discussed, is underreporting or wrong coding, acceptance, documentation gaps, and adherence. When I say acceptance, there are clinicians that it is an adverse reaction. Hence, whenever the department is capturing data, it's always important to validate the data for appropriateness. In fact, 88% of patients attending a nuclear medicine service typically receive a single dose of radiopharmaceutical. So there are no chance of repeating the dose, especially for diagnostic. For therapeutic purposes, yes, sometimes you may repeat. Aronson, etc. classified ARs into 2 types, that is predictable or dose-dependent based on the pharmacology of the drug, and unpredictable, that is not dose-dependent, that is idiosyncratic, unrelated to the pharmacology of the drug and often immunologically mediated. Of course, both of them cannot be controlled or anticipated and prevented. Although estimations of the incidence of adverse reactions vary, they cause morbidity and mortality and involve significant cost to the healthcare system. Most adverse radiopharmaceutical reactions are mild and require minimal or no treatment. This is a very interesting article. I think all of you should read. That is Gian Antonio et al. Adverse reaction to radiopharmaceuticals from Pharmacia Hospital Area. Volume 45. It's in the downloadable format in the internet. It describes more than 35 radiopharmaceuticals and their adverse reactions are mentioned in this article. Also, it's important to report these adverse radiopharmaceutical reactions in the pharmacovigilance program if you are participating in the pharmacovigilance program. I'll just give a glimpse of this, how it is described in that article. And what I would like to inform you here is, although majority, I think more than 90% of them are minor allergic reactions. So for example, DTP is one of the commonly used radionuclear pharmaceutical, and it can have signs like meningitis. Then even fatality has been reported following DTP scanning. Cardiac arrest has been reported. So it is not only important to look for or watch for these adverse reactions, but also report so that it will be easy for others to be cautious. This is another important study done by Schroeder et al. This was a patient-reported radiopharmaceutical reactions, and majority of them are general disorders and administration site conditions, and very few are nervous system disorders, and majority of them otherwise are rare. So what the paper concludes by saying that general disorders and administration site conditions and nervous system disorders are the most common. The reported frequency of patient-reported adverse reactions to diagnostic radiopharmaceutical was 2.8% in this study. And none of the adverse drug reactions related to the administration of diagnostic radiopharmaceutical were considered to be an important medical event because they are very subtle, and a few medications like chlorpheniramine maleate or antiemetics would solve the problem. Most events occurred shortly after the administration of the radiopharmaceutical and were resolved within a few hours, while 20% of the events occurred later, and these took longer time to resolve. That's what the article says. Very interesting article. All of you should go through it. So having said that, whether these adverse reactions or the allergic reactions can be prevented by pre-medications. There are a few large-scale controlled trials on pre-medication treatments, which usually not necessary. Evidence mostly comes from the case reports, expert opinions, and clinical guidelines rather than a case series or a series of events. Usually reserved for patients with known hypersensitivity or high risk of reactions or allergic, and diagnostic radiopharmaceuticals usually no pre-medications required. This is what the recommendation is. For the therapeutic radiopharmaceuticals, pre-medication might be needed depending on the agent and the patient, depending on the previous administration experiences. You may have to give anti-appendix or anti-allergics. Otherwise, most often it is not required. Organizations like ENM, that is European Association of Nuclear Medicine, and SNMMI, that is Society of Nuclear Medicine and Molecular Imaging, do not generally mandate pre-medication, but recommend monitoring for reactions and report it through pharmacovigilance program so that others are alerted for possible adverse reactions following neuropharmaceutical administrations, nuclear pharmaceutical administrations. That is the first indicator. The next indicator I'm going to discuss is on ophthalmology, that is post-operative endophthalmitis rate. Endophthalmitis is a severe inflammation of the inner structures of the eye, often caused by infection. It can occur following various procedures, including cataract surgery, intravitreal injections, and pars plana vitrectomy. It's called acute within 2 weeks of operation or delayed onset more than 2 weeks after operations. Post-operative endophthalmitis is an inflammatory condition of the eye presumed to be due to an infectious process from bacteria, fungus, or rarely due to parasites that enter the eye during perioperative period. All patients undergoing cataract surgery should be evaluated for any potential risk factors that can enhance the development of post-op endophthalmitis, and it is characterized by pain, redness, decreased vision, and can lead to vision loss if not treated promptly. So managing the intraoperative risk and prophylaxis protocols should be considered in order to reduce the risk of endophthalmitis. And early follow-up after cataract surgery is highly recommended to detect any sign of endophthalmitis so as to treat it immediately and ensure patient compliance on post-surgery medication and precautions to reduce the serious complications caused by late diagnosis and treatment of post-cataract endophthalmitis. And then nowadays, most of these cataract surgeries and ophthalmic surgeries are on daycare basis. So you need to have a strict follow protocol so as to detect early and treat this post-operative endophthalmitis. The most common causative organisms are mainly from Staphylococcus group, Coagulus negative, Coagulus positive Staphylococcus, Staphylococcus epidermidis. Then the gram-negative bacilli, Candida, Haemophilus influenza, Streptococcus species, Pseudomonas, and Propionibacterium are the most common organisms. I'm highlighting this because your antibiotic coverage should cover all these possible organisms. In the past, endophthalmitis after cataract surgery was accountable for the majority of cases, but is becoming less frequent due to the progress of surgical techniques and demographic developments with a steadily increasing number of intravitreal injections. What are the factors that affect the final visual outcome in such patients? That include pre-treatment factors like diabetes, hemodialysis, baseline vision, signs of vitreous opacity, and different surgeries before endophthalmitis. Or the treatment-related factors like the choice factors between IVI of antibiotics alone, intravitreal injection of antibiotics alone, and vitrectomy combined with the IVI of antibiotics and the injection number of antibiotics. Post-treatment factors include retinal detachment and glaucoma and macular pucker. So this is a mandatory indicator if the ophthalmology department is in the scope. You have to calculate it monthly, and it includes OP, IP, or daycare surgeries, what you do. And the formula is very simple. The number of cases of post-operative endophthalmitis into 100 divided total number of ophthalmic surgeries. You can retrieve the data from EMR if the medical records is totally electronic, or there should be provision for entering the data manually or electronically collected data. Can have apps or online forms to capture this data. OT register can have this data in the ophthalmology OTs. And data from MRD or discharge cell also can be collected. And who can collect the data? Either it's a medical records officer or ophthalmologist or the patient care executives can collect this data and keep it ready. So what are the benchmarks? If you see what trends indicate improvement or concern, the incidence of post-operative endophthalmitis is very rare, between 0.036% to 0.36%. For cataract surgeries, it's around 0.03 to 0.3%. Glaucoma surgery and intraocular lens implantation is around 0.21%. And pars plana vitrectomy, it's very, very rare, approximately 0.0 to 0.05%. This is the international incidence of post-operative endophthalmitis. Even one post-operative endophthalmitis is a significant concern, because I think Eye Care Organization in NABS describes it as a sentinel event for post-operative endophthalmitis. So serious, very prompt interventions need to be done to prevent endophthalmitis in such situations. Common challenges remain the same: unreporting, wrong coding, acceptance and documentation gaps, adherence, etc., and data validation to be done if it is done from the clinician side. The next indicator I'm going to discuss is on the rehabilitation, functional gain following rehabilitation. This is the indicator. Functional gain refers to improvement in physical activity and quality. It is a measure of improved physical function, means to say increased strength, flexibility, coordination, and balance, allowing individuals to move more easily and perform tasks like walking, dressing, and eating independently. Enhance self-care abilities, like the ability to perform personal care tasks such as bathing, toileting, and grooming, and better communication skills, like to improve their ability to understand and express themselves. It's also a measure of improved cognitive function, like addresses cognitive impairments like memory, attention, problem solving, which can impact the daily living. Increased participation in daily life, and that is ability to participate more fully in social, recreational, and occupational activities, and enhance psychosocial well-being, that is aiming at increased confidence, reduced anxiety and depression, and an overall improvement in the quality of life. So that is what is meant by functional gain. And this is important to measure the functional gain following rehabilitation. And the good news from NABH is that it's applicable only to neuro-rehabilitation inpatients. It's only for neuro-rehabilitation, and it's only for inpatient, not for outpatients or daycare patients. The frequency is monthly, includes inpatients only, and applicable to only to neuro-rehab. It says the sum of the functional gain achieved before the discharge in patients undergoing neurorehabilitation into 100 divided by the total number of patients undergoing neurorehabilitation. Very, very simple. The sum of the functional gain achieved before the discharge in patients undergoing neurorehabilitation into 100 divided by the total number of patients undergoing neurorehabilitation. I am sure that I have confused all of you. Let's see how to measure this functional gain. Before that, we will complete the usual stuff. That is, you can retrieve this data from EMR. There should be provision for entering the manual or electronically collected data, can have apps or online forms to capture. The rehab register can have this data. And who can collect this data? Either physiotherapist, rehabilitation nurse, or patient care coordinator can collect this data. The common challenges remain the same because underreporting, wrong coding, acceptance, documentation gaps, and adherence can happen. So need to have data validation always. So these are some of the measures of functional gain. There are many measures like Fiegel-Mayer assessment, work balance scale, 6-minute walk test, gait speed, and timed up. But one of the most acceptable, most internationally accepted measure is a functional independence measure, also is recommended by NIBH, that is FIM. We will be seeing much more on FIM. Before going to that, to note that this indicator is applicable only to inpatients. Applicable only to neurorehabilitation patients, example, stroke, trauma, spinal injury, or post-neurosurgery, etc. The organization shall, that means it becomes mandatory, use the FIM scale, functional independence measure scale, and this scale measures physical and cognitive disability ranging from 18 to 126. The minimum score in this is 18 and the maximum score is 126. Higher the score, more independence for patients. And this is measure of disability for a variety of population and is not specific to any diagnosis. So a little more information on FIM. It's a 19-item, 7-level ordinal scale used to assess patients' functional independence and level of disability. These are the 18 measures. There are 5 on cognitive items and 13 on motor items like eating, grooming, bathing, dressing, upper body, lower body, toileting, bladder management, bowel management, bed chair, wheelchair, toilet, tub, shower, walk, wheelchair, and stairs. And the cognitive items include comprehension, expression, social interaction, problem solving, and memory. These 18 measures are measured under the scale of 5. The scoring levels are 1 to 7. 7 indicating complete independence, 6 modified independence, 5 supervision, 4 minimal assistance, 3 moderate assistance, 2 maximal assistance, and 1 complete assistance. So each score is multiplied by the scale 1 to 7, total assistance to complete independence. And again, it is very clearly mentioned in the FIM rating that the total assistance is totally independent for more than 8 hours a day, or 31 to 53, that is level 2 maximum assistance for 6 to 7 hours. So this is how it is graded based on the FIM scoring. And since there are 18 measures into 7 scores, so it comes to the maximum score of 126 and the minimum score of 18. So 1 to 7 scoring. So even everything, if he scores 1, so the total score will be 18. That means to say total assistance is required is in level 1. And as your rehabilitation improves the functional impairment, then the score may improve and score may accordingly increase in such situations. That is what you need to have. Here they specifically say the burden of care ends at level 6 because after 6, it is patients are totally independent and they can take care of themselves. That's what it mentions. The FIM instrument refers to a scale that is used to measure one's ability to function with independence. Score is collected within 72 hours after admission to the rehabilitation unit, within 72 hours before discharge, and between 80 to 120 days after discharge. So this is the recommendation by the FIM instrument. So it should be collected within 72 hours and then 3 days before discharge and between 80 to 120 days after discharge. Score ranges from 1 to 7, with 1 being the lowest possible score and the 7 being the highest possible or the best possible score. A final summed score is created and it ranges from 18 to 126, where 18 represents complete dependence, total assistance, and 126 represents complete dependence. film scores and discharge disposition. With a high film scores, that is usually after 80, indicate a high level of independence and are strongly associated with the discharge to home. Patient can be discharged if the FM score is more than 80. Mid-range FM scores show variability in discharge destination, with some patients returning home and others requiring more support. They may be referred to a lower level of healthcare to support a few more days. Whereas low FM scores, typically below 40, suggest a greater need for assistance and are more likely to be associated with a discharge to a facility because they may require a lot of support for a prolonged time. So a total FIM gain of more than 22 or motor FIM gain of more than 17 reliably indicates clinically meaningful improvement during rehabilitation. This is a kind of benchmark which they have given. I repeat, a total FIM gain of more than 22 or more, a motor FIM gain of more than 17 reliably indicates clinically meaningful improvement. A cognitive FIM gain of more than 3 also reflects noticeable change through cognitive scale, though cognitive scale is less responsive overall. Cognitive scale, more stress is given on the motor scale rather than cognitive scale here. Cognitive scale more than 3 reflects noticeable change, though cognitive subscale is less responsive overall. These thresholds are valuable in outcome tracking, goal setting, evaluating care efficiency, and discharge planning. Although it recommends 3 FIM scores during the hospital stay and after discharge, you can apply as many as possible so that it's a measure of your rehabilitation services and it evaluates your care efficiency also. So benchmarks I have already discussed. So there are no international benchmarks. The idea is to only to improve. I can suggest a few like 100% calculation of FM score at discharge for discharge planning. Your discharge planning should depend on the FM scoring at 3 days or before the discharge. 80% of the neuro rehab achieve a film score of more than 80 at discharge. That means that they are much more independent. And 30% increase in FM score at day 3 versus day of discharge in 80% patients and above. This is just an arbitrary benchmark which I have given. You can have your own hospital benchmarks and you can follow it up. I repeat, 100% calculation of FM score 3 days before discharge so that you can plan your discharge based on the FM score. 80% neuro rehabilitative achieve a FM score of more than 80 at discharge and 30% increase in FM score at day 3 versus day of discharge in 80% patients and above. So that it's a very, very good measure of your neuro rehabilitation services in your hospital. So I stop at that point. You can read further. Those 2 articles which I have mentioned are very good, very useful articles. You can go through this. That is, one is Gadomski et al. And another one is the Uniform Data System for Medical Rehabilitation. This is directly from the FIM who introduced FIM. Is the persons who introduced FIM. The 4th indicator and last indicator for today is in the emergency department. The time taken for triage. Triage is a process of prioritizing patients based on their severity of the condition so as to treat as many as possible when resources are insufficient for all to be treated immediately. The sorting of patients according to the criteria which ensures that the most seriously ill or injured patient is treated before patients with less serious problems. And many of us have got this confusion whether the time taken for triage is same as the time taken for initial assessment in the emergency department. The answer is a big no. There are 3 different time you need to monitor in the triage in the emergency department. That is time taken for triage, time taken for initial assessment, and time taken for disposition. So these 3 are different topics altogether. The only thing is the common finding in this is the start time, that is time at which patient has arrived. All the 3 will have the common time, the time at which patient has arrived to the emergency department. The end time for the time taken for triage is time at which triage is completed. Initial assessment is time at which initial assessment is documented. And disposition is the time at which the patient is disposed from the emergency department. So it becomes mandatory because most of the hospitals do have this emergency department, and it has to be collected daily for every patient and to be evaluated monthly. The indicator is very simple: sum of time taken in minutes for triage divided by total number of patients coming to the emergency. Please note that there is no multiplier. So it is on an average, what is the number of time, what is the time taken in minutes for triaging every patient. We can retrieve this data from EMR, or there should be provision for entering the manual electronically collected data. Can have apps, online forms to capture, register can have the data, and who can collect the data? Either ED doctors, nurse, or patient care coordinators. Again, underreporting, wrong coding, acceptance, documentation gaps, and adherence can be the challenges. Please do a data validation, because whenever we go for the assessment, we see that the benchmark is given that the patient should be seen within 5 minutes in after entering the emergency department. And when we look at the record, it says patient came at 9 o'clock, 9:05 he is seen. A patient came at 9:15, 9:20 is seen. Patient came at 9:17, patient was seen at 9:22. Usually the data entered is 5 minutes after the entry of the patient. Actual data may be different. So please do not do such waste exercises. Please try to track the real-time data and try to get the benefit out of it. Again, the start time, I told you all the three indicators have the same start time when the patient entered the emergency department. Time at which patient entered the emergency department versus the end time is when the triage is complete. A very, very interesting article from Acharya, RP, and et al. On emergency department triage with an ethical analysis, and very, very interesting findings are there in this. Please go through this article. Very, very interesting findings are there. And most of our hospitals do oscillation triaging scale, that is level 1 to 5. And the oscillation triaging scale, ATS, which is applicable in Australia and New Zealand, indicate these benchmarks. That is 0 for level 1, that is where resuscitation is required. Other emergency patients, it's less than 10 minutes, urgent less than 30 minutes, semi-urgent more less than 60 minutes, and non-urgent less than 120 minutes. But most of us do happen, most of these, all these kind of emergencies, we do address them within triaging within probably 5 to 10 minutes. It happens. Aim for 97%. This is what is recommended by Australian triage scale. Aim for more than 97% compliance for levels 1 to 2 and more than 90% compliance for level 3 to 5. This is what is Australian triage scale mentions. Very similar triage system is there in the Canadian triage than the acuity scale. Again, the same level 5 and almost the same except for I think 15 at level 2. Otherwise 0, 10, 30, 60, 120 remains 0, 15, 30, 60, 120. That remains the same. They are given the targets that more than 98% in level 1, more than 95% in level 2, more than 90% in level 3, more than 95% in level 4, and more than 80% in level 5. So it depends on the lower seriousness of the patient. You can take a little more time in triaging these patients. And they also say that more than 80% compliance is required based on whatever benchmark you have put in your hospital. A very similar triaging system based on the Manchester triage system, mainly used in UK and Europe. Again, the categories are same, level 5 categories, but the timings are benchmarks they have given is like 0, 10, 60, 120, and 240. Whereas some countries like Germany, the target for level 5 is less than 120. And these are common triaging systems. I will not go into the depth of this. 5 triaging systems. Many of you are following it. Please continue the good habit. In Indian benchmarks, if you see All Institute of Medical Science protocol disposition timings, this is also called as disposition time. Here refers to being seen by a clinician and not discharge time. For the red cases, it's around within 10 minutes of arrival. For yellow, within 30 minutes, and green within 4 hours. They have mentioned as the triage protocol. So time to initial assessment from arrival to first clinical assessment for ambulance arrives is less than 15 minutes. So this is now the most of the hospitals do pre-hospital assessment and triaging. So the triaging would have been already done during the transit time in the ambulance itself. So it should not be more than 15 minutes when they arrive in the emergency department. This is a very, very important article, actually downloadable format PDF book. Operational and technical guidelines on emergency care services at district hospitals from Ministry of Health and Family Welfare, Government of India. A lot of information on emergency care is there, including triaging. So you can download this book in the internet and follow it. These are the standards which are applicable for district hospitals under the government sector. There is an interesting study done by AIMS, All India Medical Science, Delhi, a quality improvement project aimed to reduce the door to triage wait time from 50 to under 30 minutes. And they did a lot of measures to reduce it. After 6 weeks, they could strike a median time of 12 minutes. An amazingly fantastic job done. You can go through this article also, which is available, mainly done by Ashok Deorari et al. So that's about, in a nutshell, about the 4 indicators which I'm supposed to discuss. If there are any questions, please feel free to ask.
Thank you. Thank you so much, Sunil sir. There are a couple of questions. I'll start from your questions. So the one is, could the triage completion time and assessment completion time be the same?
No,
I
no,
think you answered that.
I have already answered.
Yeah. So certainly the PowerPoint presentations will be shared with all of you. The first set had about 900 plus registrations, and today again another set of 900. Many of you could not join because our link is limited to 500 plus. So what we would be doing is to share the presentation with all of you. All the 4 presentations, maybe we'll put them all together and share with you. Then about, in case 30 patients are admitted daily and we do GRBS for 10 times, do we need to capture all? I think, Sanjeev sir, the most controversial indicator is the point of care testing. One person has also asked for a repeat of that. There are several questions on POCT. Would you like to take them, sir?
Yeah, so can I take the questions what has been written one by one?
Yeah, let me, okay. One is by Arun Kumar. In case 30 patients are admitted daily and we do GRBS for 10 times, which is 30 into 10. I don't know why they would do for all of them. Do we need to capture all?
Yeah, the point is yes, you need to capture all because we are doing point of care testing only for clinical indication. And wherever there is any hypo or hyper, you intervene, and that is where that would come as a numerator.
I think that's exactly the question another person has also asked.
Yeah.
So do we need to include all of that? Okay. So the other important question is it only limited to a particular point of care testing, or ultrasound on-site, portable X-ray, all those should also be considered?
So this is a very, very good question, and it has to be considered. With an ultrasound, it is called as focus point of care ultrasound. And those are, again, very important for clinical decision making. So other than the lab, sonography is included and it should be definitely considered.
Exactly. Including all the echo, ultrasound, everything, isn't it?
Correct. Bedside, yeah, bedside,
Bedside.
all these procedures, yeah.
Yeah.
But that's a good question.
All right. Yeah, the same question is repeating again with regards to the number of times glucometer and yeah. All right. If there are any questions, kindly put them up. Yeah. So somebody, Kirti is asking, is it not under biochemistry? Maybe the GRBS one, sir. But it is using the glucometer, isn't it? That's when.
Correct.
Yeah.
So it is dependent on wherever the geography is. It could be ICU, it could be ER, it could be under biochemistry also. It is hospital dependent. Wherever you can track this information, that can be done.
Yeah. So again, the extravasation one, sir. Should it be in cath also? Contrast in cath lab should be.
Absolutely. Yeah, absolutely.
Yeah. Sometimes the GRBS is for monitoring, Q2H or Q4H monitoring. Should that be also as part of the indicator?
100%, because the definition of point of care test will remain the same. So your denominator will remain the same. On some of it, you are taking a clinical intervention. So that's a numerator. So denominator will not change. So even if you are doing it for screening, that will remain.
Yes, sir. Now this is to Sunil, sir. If we are using the Barthel index for checking functional capacity of patients after physiotherapy, do we have to introduce the FIM scale, FIM scale? Because more or less all the parameters are the same.
The NABH standard recommends FIM scale, and they have mentioned specifically FIM scale. So it's better to shift to F5 scale because it also indicates cognitive abilities.
Then from Dr. Rajshri, monthly about 2000 plus patients go to the ER. Time is manually entered in the ER register. For monthly triage time analysis, can we use sample size or should we take the entire thing? That's her question.
It's the entire thing. Since you are documenting it as a record, you can make an electronic or Excel sheet and record this, and it will be easy for you to capture the data. Take it for 100%. There's no problem. It's good for you to capture.
Absolutely. Since already you're capturing anyway.
Yeah.
Then Ajay also is the same question. Can we take the sample size for the emergency indicator?
It's better not to. For emergency indicators, it's always 100% sample that's required. And it is easy to capture also. When you're capturing the data, capture it for 100% and then capture it. The sample size, then sampling, then stratification, and then all those additional points will come. So it's better to capture for 100% data.
Perfect. There is a clarification, I think, Sanjeev sir. NABH book says that POCT needs to be captured in biochemistry only. So please explain why we are taking bedside ultrasound and X-ray.
I will refer and then come back if it is limited. Just give me a minute.
Yes, sir. Any tool for neonatal sepsis, Sanjeev sir?
It remains the same. We basically are looking at only, as far as the indicator, we are looking at 1 hour bundle, which is true for everybody, which is true for neonatal, pediatric, as well as for adult.
Clarify this doubt, dear participants. So once again, I wish to thank Dr. Sanjeev Singh and Dr. Suneel Mundkur for the wonderful session. And what we are going to be doing is to share the PowerPoint presentations used by all the 4 speakers, rather 3 speakers. Sunil sir handled 2 sessions last week as well. So the PowerPoint presentations will be shared with all of you. Some of the questions that we have noted down will also be shared with the answers with you. And I would like to take this opportunity to propose to you to join another program which will be very, very interesting for all of you as quality managers, leaders in quality improvement program. That is about the department indicators that's coming up. It's a masterclass series with about 18 sessions. So if you have not registered, kindly register for this program. Any clarifications and any queries regarding this particular program that we are launching, kindly contact Anita at Kaho. So if you wish to join for all the 18 masterclass sessions, you could do that. Or specifically, some hospitals may want their cardiothoracic surgeons and cardiologists to attend one session. Then you can pick and choose as well. So this is a good way to get your clinical departments also involved in this exercise. And this carries Kaho credit points of about 18.